You know that flaky scalp you sometimes see on babies? It looks a bit crusty, maybe yellowish.
Cradle cap, very common.
Exactly. It often worries new parents, but it's usually pediatric seborrhoeic dermatitis. And that's what we're really getting into today.
Yep, we're pulling the key info from Paediatric Seborrhoeic Dermatitis, a comprehensive overview.
Our mission here is to give you a super clear, high-yield rundown. Think of it as cutting through the noise so you feel confident about this condition, maybe for revision or just general knowledge.
Sounds good. Let's start with the basics then. What is it?
Okay, so pediatric seborrhoeic dermatitis, it's a common, often chronic inflammatory skin thing.
Right, and it particularly likes areas with lots of oil glands, sebaceous glands.
So we're talking scalp, face, sometimes the trunk.
Precisely. Scalp, face, chest, back, those kinds of areas. And the signs you're looking for are typically redness, some scaling or flaking, and maybe a bit of itching.
Okay, redness, scaling, itching in oily areas. Got it. So what's actually causing this? What's the etiology?
Well, it seems to be a combination of things, not just one single cause.
Ah, okay. Like what?
First, there's often an overgrowth of a type of yeast, a fungus called Malassezia. It normally lives on the skin, but sometimes its numbers increase.
Right, Malassezia. What else?
Then there's sebum, the skin's natural oil. Either too much is produced or maybe the composition, the sort of makeup of the oil is a bit different.
Interesting. So fungus and oil. Anything else?
Genetics can play a part. Some families just seem more prone to it.
Makes sense.
And finally, there's the immune response. The body might react abnormally, maybe overreact to the Malassezia itself or to other inflammatory triggers in the skin.
So it's like a perfect storm of factors.
Kind of, yeah. You could think of it like a garden. The Malassezia yeast is, let's say, always present, like a type of fungus in the soil.
Okay.
Now imagine you suddenly add way too much fertilizer or maybe the wrong type of fertilizer that's like the excess or altered sebum.
Ah, so the fungus thrives.
Exactly. It overgrows. And this overgrowth, plus maybe the body's reaction to it, triggers the inflammation, the redness, and the scaling. It all sort of feeds into each other.
That analogy really helps, actually. So who's most likely to get this? Are there specific risk factors?
Definitely. Age is a big one. We see it loads in young infants. That's your classic cradle cat presentation, usually in the first few months.
Right.
And then, interestingly, it can reappear or show up during adolescence, probably linked to hormonal changes affecting sebum production then.
Okay, infants and teens. What else?
Family history. If parents or siblings had it, a child might be more likely to develop it.
Runs in families sometimes then.
Also, certain underlying medical conditions can be a factor. Things like immunodeficiency, some neurological disorders, and also HIV/AIDS.
Okay, important to bear in mind.
And one more thing, seasonality. Some people find it gets worse in the colder, drier months, winter flares, basically.
Right, the central heating effect, maybe. Okay, so let's dig a bit deeper into the skin itself. What's the pathophysiology? What's happening on that, like, cellular level?
So it starts with that increased Malassezia colonization we mentioned.
The yeast overgrowth.
Yeah. That seems to trigger an inflammatory cascade in the skin.
Yeah.
And part of that response involves speeding up the skin cell turnover.
So skin cells are being made and shed too quickly.
Exactly. That rapid turnover, plus the inflammation itself, is what leads to the visible signs, the redness, the scales, the flakes, and the associated itching.
Makes sense.
It's worth saying, though, that the exact detailed molecular pathways, how A precisely leads to B and C, that's still being actively researched. There's still some stuff we don't fully understand.
Always more to learn in medicine, isn't there?
Yeah.
Now, you mentioned redness and scaling. That sounds like it could look like other common skin conditions in kids.
Oh, absolutely. The differential diagnosis is really key here.
What are the main mimics we need to think about?
Okay, number one is probably atopic dermatitis or eczema. It can look very similar, especially with red, scaly patches. The big clue often is that atopic dermatitis is usually intensely itchy.
Ah, okay. Itch intensity is a differentiator. What else?
Psoriasis, especially in infants, psoriasis can sometimes present quite similarly to seborrhoeic dermatitis. Look for maybe thicker, more silvery scales sometimes.
Right, psoriasis.
Then there's contact dermatitis, a reaction to something touching the skin, like a soap or a cream. History is key there.
Did something new touch the skin?
Exactly. On the scalp specifically, you have to consider tinea capitis. That's a fungal infection, but a different type of fungus, not Malassezia. needs specific antifungal treatment.
Okay, Tinea capitis for the scalp.
If you see weepy, crusty bits, think about impetigo, that's a bacterial infection, often secondary.
Right, licks infected.
And down in the nappy area, you've got nappy rash itself, and also candidiasis, which is a yeast infection. Again, different yeast, usually candida.
How does that look different?
Candidiasis often has really bright red patches, sharply defined borders, and sometimes these little satellite spots around the main rash, right in the groin folds. Sebderm tends to be less fiery red, maybe more yellowish scale.
Good distinction. Any others?
Just simple irritant dermatitis, maybe from dribble around the mouth or harsh soaps.
Wow, that's quite a list to keep in mind. Is there any quick way to remember the main ones? Maybe a mnemonic?
Let's see, how about thinking about the features? Is it atopic, very itchy, psoriatic, silvery scales maybe, contact, new exposure, infected, crusty weepy impetigo or tinea on scalp, or nappy area specific, candidiasis nappy rash? Does APC-18 work? Atopic, psoriasis, contact, impetigo, tinea, irritant, nappy, candidiasis.
APC-18. Okay, APC-ITN. Atopic, psoriasis, contact, impetigo, tinea, irritant, nappy, candidiasis. Yeah, that could be helpful. Thanks. So how common is this condition overall in kids, epidemiology-wise?
It's super common, especially in infants. Like we said with cradle cap, a huge percentage of babies get some degree of it.
So parents shouldn't panic if they see it.
Definitely not. The good news is the prevalence really drops off as kids get older. And most infant cases, the cradle cap type, tend to clear up completely on their own, often within, a few weeks or months.
That's reassuring.
Yeah.
Okay, let's get visual. What does it actually look like on different parts of the body? Can you describe the clinical features?
Sure. Let's start with the scalp, which is probably the most classic site in babies.
Cradle cap central.
Right. You'll typically see scaling. It can be fine and flaky or quite thick, greasy, maybe yellowish or brownish crusts. That's your typical cradle cap look.
Greasy, yellow scales or crusts.
Sometimes there can even be a little bit of temporary hair loss in those areas, but it grows back.
Okay. What about the face?
On the face, you might see redness and some finer scaling. Common spots are the forehead, eyebrows, sometimes in the folds beside the nose, the nasolabial folds, and even on the cheeks.
Forehead, eyebrows, nose folds, cheeks.
Yeah. And moving down to the trunk, the chest or back, you might see sort of roundish or oval patches of redness with some scale, sometimes called a petaloid pattern.
Okay. And is it usually itchy?
It can be itchy, but generally it's quite mild, especially in infants. They're not usually distressed by it, unlike, say, severe eczema.
So not intensely itchy like atopic dermatitis?
Generally, no. And just remember, the appearance can vary a bit. The scalp often looks more scaly and crusty, while the face and body might be more about the redness with finer scale.
Gotcha. Any other sneaky spots it hides?
Oh yeah, always check the folds. Behind the ears is common, in the neck creases, armpits, and even the groin folds or nappy area.
Good to check the folds. Okay, so we see something that looks like this. How do we actually make the diagnosis? Are tests usually needed?
Honestly, most of the time, no. The diagnosis is usually clinical.
Based on the look and location.
Exactly. You see that characteristic greasy scale, maybe some redness in those typical sebaceous areas, scalp, face, folds, and the history fits, especially the age group. Usually that's enough.
So not routinely sending off swabs or anything?
Not routinely. But there are times you might consider investigations.
Like what?
Well, if the diagnosis just isn't clear, if it looks a bit unusual, or if it's not responding to standard treatment, you might think about it.
What kind of tests?
A skin biopsy could be done in uncertain cases to help differentiate from things like psoriasis or other rarer conditions. A small sample of skin is taken and looked at under the microscope.
Okay. Biopsy if unsure.
And if you strongly suspect a fungal infection like Tinea capitis on the scalp, then taking a skin scraping or hair sample for fungal culture makes sense.
To check for that specific fungus.
Right. But here's a crucial point. A negative fungal culture doesn't rule out seborrhoeic dermatitis.
Why is that?
Because Malassezia, the yeast usually involved in sebderm, is actually quite hard to grow in standard lab cultures. So a negative result doesn't mean it's not there or not involved.
Ah, okay. That's really important to remember. Negative culture doesn't exclude it. So mostly clinical diagnosis. Now, management. What's a general approach, say, in the UK context?
The cornerstone is gentle skincare, using mild, non-irritating cleansers.
Keep it simple.
Yes. And applying emollients, moisturizers, regularly can help with dryness and sometimes soften scales.
Makes sense. What if that's not quite enough?
If it's more persistent, or if that Malassezia component seems significant, then topical antifungal creams are often used.
Like what specifically?
Common ones you'll see prescribed are things like clotrimazole 1% cream or miconazole 2% cream applied to the affected areas.
Okay, antifungals like clotrimazole or miconazole. What about the inflammation and redness?
For that, mild topical corticosteroids can be really helpful. Something like hydrocortisone 1% cream, maybe? But these should definitely be used under medical guidance, especially in babies, and usually just for short periods to settle flares.
Right, short-term steroids for flares with advice.
Exactly. And just generally avoiding triggers is good advice. Things like harsh soaps, bubble baths, maybe overheating.
Okay, that covers the general principles.
Yeah.
What about specifically for cradle cap, that thick scalp scale?
Yeah, there's a specific routine for that. First step is usually softening the scales. You can gently massage an emollient like plain baby oil, olive oil, or a specific cradle cap product into the scalp.
Leave it on for a bit.
Yeah, leave it on for a while, maybe even overnight if needed to really soften things up. Then use a soft baby brush or even a fine-toothed comb to gently lift the loosened scales away.
Gentle brushing.
Very gentle. You don't want to irritate the scalp. And then wash the hair with a mild baby shampoo. Repeat this regularly until it clears.
Okay, soften, gently brush, wash. What if that doesn't shift it?
If it's really stubborn despite that routine, then introducing one of those topical antifungal creams we mentioned, like clotrimazole or miconazole, applied to the scalp might be the next step. Or sometimes specific medicated shampoos containing antifungals or keratolytics are used in older children, but less commonly in infants.
Got it. And for the non-scalp areas in babies?
Yeah.
Like the face or body?
Similar principles. Daily gentle bathing, perhaps adding an emollient bath additive, using barrier emollients, especially in the nappy area with frequent nappy changes.
Keep the skin clean and moisturized.
Yes. And again, if there are persistent red patches, those topical antifungals, clotrimazole or miconazole, can be considered for those areas too.
When should someone maybe seek a referral or specialist advice?
Good question. Definitely if the case is very severe or widespread, if the diagnosis is really uncertain despite trying things, or if it's just not getting better with the standard treatments we've talked about, time to get another opinion then.
Okay, severe, uncertain, or not responding. Makes sense. What about the long-term picture? What's the prognosis?
Overall, it's very good, although it can be chronic, meaning it can kind of come and go for a while.
Flare-ups happen.
Flare-ups can happen, exactly. But it generally improves significantly over time. It's usually very manageable with the approaches we discussed.
That's reassuring for parents.
Absolutely. And as we mentioned, it often completely resolves by adolescence anyway. So the long-term outlook is really positive.
Good to know. Are there any potential complications we should briefly mention, even if they're rare?
Yeah, significant complications are definitely uncommon. The main one to be aware of is secondary bacterial infection.
From scratching?
Usually, yeah. If the skin gets very inflamed and itchy and there's scratching, the skin barrier can break down, allowing bacteria like Staph aureus to get in and cause an infection, like impetigo.
So managing the inflammation helps prevent that.
Precisely. The other thing, perhaps more relevant for older children or adolescents, is the potential for some psychosocial impact, feeling self-conscious about the appearance of the rash.
Understandable.
Yeah.
But mostly it's manageable without major issues.
That's the main message, yes.
Okay, so let's try and wrap this up. We've covered pediatric seborrhoeic dermatitis. It's that really common inflammatory skin condition, often starting as cradle cap in babies.
Driven by that interplay of Malassezia yeast, sebum, maybe genetics, and the immune response.
Yeah. And while it can look like other things, like eczema or psoriasis, the greasy scales in those oily areas are a big clue. And it's often not super itchy.
Diagnosis is usually clinical. Management focuses on gentle care, emollients, and sometimes topical antifungals or mild steroids for flares.
And the really key takeaway is that although it can be persistent for a while, the prognosis is generally excellent. It's manageable and often disappears completely later on.
Exactly. Reassuring parents is a huge part of it.
Definitely. A final thought, maybe, just the importance of that gentle approach, avoiding harsh treatments unless really necessary.
Absolutely. And for anyone wanting to dive deeper or consolidate this, check out PassTheMSRA.com.
And also freemsra.com for more resources.